Good afternoon, everyone. I am Dr. Devpriya Sarkar, Assistant Professor, Department of Anesthesia and Critical Care Medicine. And today we'll be talking about a very interesting topic, that is simulation in anesthesia and critical care. It is a very interesting as well as a new topic. Should I say new? Probably not, because simulation with us for last that 3 decades or something like that. So let's start with it. So first, what is simulation? Simulation is actually the act of mimicking a real object, event, or a process. Then why simulation? In 1990, the US IOM, they published one report, one very famous report, that is "To Err is Human," and it showed that average 44,000 to 98,000 of patients, they died each year due to preventable medical errors. Now in medical practice also, what principle do we follow when we treat a patient? Is first do no harm. So what was our traditional practice before that? Our traditional practice was to see one, to do one, and to teach one. But now the paradigm has been shifted to observe some, practice several, and then perform. So I will be touching the brief history of modern simulation, and it all started in the year 1928 when the link trainer was first developed. And the link trainer are actually the flight simulators. Today we have the modern version of flight simulators, but it all started in 1928 as the link trainer. Then one breakthrough came in the year 1960 when Resusci-Annie, a simulator to teach the nursing and medical professionals about the resuscitation process, were introduced in the market. After that, that there were a boom in the simulation market, and in year 2000, the current generation of full body mannequins were introduced by Metty and Lardell. And in 2005, the Society of Medical Education were established, and in 2006, the Simulation in Healthcare journal were first published. Now simulation is a very valuable teaching tool. So why simulation is a very valuable teaching tool? Because the learners can learn without risk to the patient. So first do no harm, then opportunity to repeat the lessons multiple times and to skill to mastery. Then there is guaranteed specific learning opportunity. Learning can be done at convenient time. If you are not free due to your OT works or due to your ICU duties, you can always learn during your spare time in the evening or in your night shift time, any time. Now learning can be done at your convenient times, and performance that can be recorded and observed and recorded for further analysis and debriefing. Now there are some specific purpose in medical education what simulation serves some specific purpose, like that there might be problems with some associated clinical teachings, there might be some new technologies for diagnosis or treatment, there's for assessing the professional competency, and some medical errors or patient safety and deliberate practice. Now if you look into the current Cbme curriculum, that is the competency based medical education curriculum introduced by the National Medical Commission, and if you go through the PG curriculum, that is Cbme curriculum for the postgraduate trainees in the Department of Anesthesia, you will see that it highlights basically 3 domains. One is cognitive domain, one is affective domain, and another is psychomotor domain. So in cognitive domain, that talks about the knowledge of anatomy or physiology, biochemistry, medical physics or drugs, equipment, BLS, ACLS, sterilization, oxygen therapy, ventilation, and many more topics. The affective domain, that talks about the team effort, the communication skills, ethics, cooperation, etc. And if you look into the psychomotor domain, that talks about the approach towards a case, skills, evaluation, analytics, etc. So the simulation teaching or simulation can be a valuable tool to improve all three domains, the cognitive, psychomotor and the affective domains. Now if you see the, that Miller has now dedicated at least more than I think 10% of its volume for a chapter, that is simulation in anesthesia and critical care. And if you see to the US curriculum, they, that they have introduced the anesthesia crisis resource management program, and for licensing also it is very essential that that go through these CRM programs and get yourself licensed for that. And if you go into the brief, I will just explain in brief about the crisis resource management, that talks about the, the environment, anticipate and plan, call for help early, exercise leadership and fellowship with assertiveness, distribute the workload, mobilize all available resources, prevent and manage fixation errors, cross check and double check, use cognitive aids, re-evaluate repeatedly, use good teamwork, allocate attention wisely and set priorities dynamically. So if you see, there's these crisis resource management, simulation is a very vital tool to teach you about this. Now use of simulators for the evaluation and testing of anesthesia professionals, you will be asking. So it is a required element of the part 4 of the US maintenance of certification in anesthesia program by the American Society of Anesthesiologists. Now now we'll be talking about the healthcare simulation modalities. So there are different modalities of healthcare simulation. In brief, they are the models or standardized patients or screen-based simulation, task trainers or mannequins or virtual reality or hybrid simulators. We'll be touching one by one. First, the models. Now these are very basic simulation modality, mainly used as anatomy or physiological trainers. They are very cheap and easy to use. Probably all of you have seen the model of a 3D model of a heart or 3D model of lungs like that, and you can teach your students about the anatomy and physiology of heart by these models. Now next comes the standardized patients. We use this modality of simulation too often, particularly during our examination process. Now in this process, individuals are trained to portray specific illness or behavior for the purpose of teaching or assessment. Now they are used for assessment of communication and professional competencies, required clinical skills testing for all students. Now there are some pros and there are some cons for the standardized patient. First I will touch the pros. They can consistently reproduce the clinical scenario, patient trained to provide objective and accurate feedback. They can be used for in real settings. But what are the cons? Yes, there little research is available regarding the effectiveness of this method of simulation teaching. Now cost to pay and time to teach a standardized patients is quite high, and the quality of experience heavily dependent upon the training of the patient. If the patient is getting properly trained, okay, it is fine, but if he is not that understanding it completely, then your entire simulation session can be ruined. Now there comes the technique that is known as improvised technology. So in improvised technology, what we do, the biological or synthetic models we use that closely mimics the human tissue, generally used for instruction or procedures. Examples are like slab of ribs to teach the insertion of chest tubes, or the animal feet or head for suturing practice. Now there are obviously any process or any technology, they will be having some pros, they will be having some cons. So if you see that improvised technologies, they have some pros, like they are very cheap, they are easily available, they are easy to duplicate for repetitive use or multiple users, and minimal instructor education is needed. Now what are the cons? Now they are less real life experience, therefore stress factors are removed from the equation, often does not duplicate the most difficult aspect of the procedures, like that you will get a standardized one, not for an obese patient you can mimic. Now they are static devices, they don't give you feedback, they are not dynamic, they are useful for specific procedures only, but not in a changing clinical scenarios, because in medical practice the scenarios are always changing, so they can't be used in this changing clinical scenarios. Examples are like what we have organized some workshops also here in Santosh. We have organized one percutaneous tracheostomy workshop where we use this improvised technologies, or the surgery department they regularly use the that suturing models. They are basically that some human tissue, some animal tissues or something like that, or something made from the silicone or gel like material. So these are all examples of improvised technologies. Then comes a very vital portion, the very vital tool of basically simulation teaching, that is screen based simulations. That I think that as a anesthesia postgraduate residents and also faculties also, we have to go through this basic life support and this advanced cardiac life support trainings. Okay, now if you have already gone through this basic life support or advanced life support trainings, probably you can understand that when they teach us about the different ECGs or electrocardiograph, where they mimic the ventricular tachycardia or the atrial fibrillation or the ventricular fibrillation or different kind of arrhythmias, and they ask us to diagnose and that to treat those kind of scenarios. So these are examples of screen based simulation. The most commonly used is ECG simulators, or there are some mechanical ventilation simulators also available in the market, like X-lung, something like that. Now there are some certain pros and some cons. They are usually very low cost simulators. They the distance learning can be possible. They are that sometimes like this some ECG simulators and some mechanical ventilation simulators, they are cloud based and subscription based, so you can subscribe and you can learn from the comfort of your home. Now variety of cases are possible. Sometimes that you will be coming across with the ECG simulators that can mimic 150 or 50 or 100 different ECG clinical scenarios, and you can program your own ECG also. Some ABG simulators are also there, and some mechanical ventilation simulator. You can change your scenarios, you can increase the compliance, you can decrease the compliance, you can increase the resistance, you can decrease the resistance, and you can create ARDS scenarios or COPD scenarios. And these are basically good, and they are very good for self-directed learnings, and variety of cases can be created. But that if you will be asking what are the cons of these simulators, now no procedure skills are involved in this kind of simulators, no teamwork skills, no communication skills, no real life experience are possible with this kind of simulation teaching. Now comes the backbone of the medical simulation. Those are basically the task trainers. When you are a medical professional, you have to perform different tasks during your clinical rounds, or that seeing a real life patient. You can put an intracath, or you can put a Foley's catheter, or you have to put an endotracheal tube or some ICD or something like that. But that what I told you earlier, that the traditional teaching, now the paradigm has shifted to the first observe some, okay, and then practice some. So where you will be practicing on the real life patient? No, we want no harm to the patient, so you will be practicing in simulators. So those simulators, they will that help you gaining proficiency or gaining mastery over particular skill or task, are known as task trainers. Now they are the devices, those are designed to simulate a specific task or procedures. Example are pericardiocentesis task trainer, or bronch simulator, or IV line simulator, or airway simulator, or chest tube, or center line. These are very that few examples that I am giving. Lots of task trainers are available in the market. Regularly in Department of Anesthesia, Santosh Medical College Hospital, we regularly we have introduced that this simulation and skill based training in our weekly teaching curriculum for the postgraduate residents. And Saturday we send them to the skill lab. We have the central skill lab in the medical college, we have departmental skill lab in the hospital also. And we that send them different kind of scenario like airway management task training or central line. We have these task trainers and trainees, that they can use this n number of times, no problem, because no harms associated. So they are gaining that adequate mastery in this kind of task like airway training, airway or intubation or central line insertion or ICD insertion, like that. Now these task trainers have some pros, like they are very high fidelity trainers. They are very good, that research and efficacy are quite proven, and they may have self-guided teaching also. Some task trainers, they come with some that visual feedback or some digital feedbacks, like that intubation trainer, where you, if you go into the trachea, that will give you the feedback, okay, you are inside the trachea. If you will be that going inside the esophagus, they will be immediately telling you, okay, you have performed something wrong, you are inside the esophagus, you remove your tube and something, and the lungs you are not ventilating. So they give you a good feedback. Okay, now the cons are that when they are giving you the feedback and they are high fidelity, so they are quite expensive. And most of the task trainers, if you see, they are basically particularly focused on a single task. If I am using a airway trainer, so it is focused on the airway training only. If I am using a central venous catheterization trainer or some pelvic trainer or some suture training mannequins or something like that, so they are basically focused on a single task, and they are not integrated into the complete patient care. So the immersive experience, the real life experience, those are lacking. Now very that one of the cornerstone are mannequins. Now these mannequins, that I have mentioned at the beginning of my lecture, that in 1960s basically they came up with the resuscitation to teach the nurses and the medical professionals about the resuscitation process. So now we have different kind of mannequins, those are that used for simulation teaching, and they can be divided into grossly into low fidelity mannequins or mid fidelity mannequins or high fidelity mannequins. Now if I go through the low fidelity mannequins, now low fidelity means that they have some feedback that mechanism, or they might not be having some feedback mechanism, and they have some features like they have some static airways, they can generate rhythm like heart rhythm, or no or minimal programmed responses. There might be no or minimal programmed responses. Yes, there are minimal programmed responses. Now the pros are they are really that they these mannequins are quite low cost mannequins, they are quite reliable, and they are easy to use, and they are portable. And if you use this kind of low fidelity mannequins and not much instructor training is required, yes, instructor training is required but not that much. But that in con side they have very limited features and they are less interactive. Then we'll be coming towards the mid fidelity mannequins that we use for simulation training in anesthesia and critical care. They are relatively newer generation of mannequins, often used for ACLS training. Probably you have gone through ACLS trainings. Now they have active airways, that you can put endotracheal tube, you can put a laryngeal mask airway, you can put a combi tube. Now they can generate breathing patterns, they have pulses or rhythm that you can measure. You can perform certain basic procedures like pacing or defibrillation, and they will respond to your treatment. And some automated responses are programmed and scenarios can be created. Some examples of the low mid fidelity mannequins, like we have this Braden CPR training mannequin, or the that Braden baby, those are for the the pediatric cardiac life support training mannequins, like that. Now there are certain pros of these mid fidelity mannequins. So those are, they have active airways, they are somehow interactive, and the costs are relatively moderate, and they have some moderate portability, not like the low cost mannequin, but yes, much better than the high fidelity mannequins. But some weaknesses are there, that semi skilled instructors are needed, some limited or advanced procedures can be performed in these mid fidelity mannequins. In high fidelity mannequins, we have these mannequins with electrical pneumatic functions driven by a computer. The examples are Maverick Medvision Leonardo Human Patient Simulator, Maverick Medvision Mia Pediatric HPS, Maverick Neosim Lucy, that is lung simulator in infant, that is a neonatal mechanical ventilation simulator, or CAE, that is Canadian Aeronautical Engineering, so Lucina, that is basically a pregnant female simulator. Now in high fidelity mannequins, they have certain features like dynamic airways, the reactive pupils, heart sounds, lung sounds, chest movement, pulse rhythms, vital signs, abdominal sounds, voice, carbon dioxide exhalation, cardiac output, invasive pressure, bleeding, salivation, lacrimation, whatever you can think. Now you can perform certain procedures in these high fidelity mannequins also, like you can give oxygen or bag valve mask ventilation, oral or nasal airway, ETT, LMA, tracheostomy, Crick's, etc., pericardiocentesis, defibrillation, pacing, CPR, needle or open thoracocentesis, TOF or monitoring, that is your TOF monitoring for anesthesia, internal gas analysis, Foley's catheter placement. And these mannequins, they react to the medications. If you giving correct medications, they will be reacting correctly. If you will be giving incorrect medication, they will be reacting incorrectly. Now there are certain pros and cons associated with these mannequins, like the many dynamic responses can be programmed to programmable scenarios, can be n number of scenarios you can create. They have the widest variety of procedures available with them, and they will give you the most immersive experience in simulation teaching or learning. But they are quite costly. The portability, yes, definitely is an issue, and significant instructor training is required. Now if you plan a scenario in high fidelity mannequins, there are certain things that first you have to give the trainees about the objectives of the program. Then if you create a scenario, we'll be giving them a case history, a brief description of the case, some learning objectives and some goals, some medias will be there, the reports you can share the real time patient reports with them, some real reports, and obviously if they perform the process, after that you can go with the debriefing process. Now then comes the virtual reality simulation. These are very advanced form of human computer interaction, like immersive virtual reality or desktop virtual reality or pseudo virtual reality. They are mainly used for flight simulation. For medical use, we have this endovision, angiovision for PTCA training, the IC for ophthalmic in the that ophthalmoscopy, the lab vision hybrid for laparoscopic training, like that. Those are the simulators by Medvision group. Then we have some desktop VR, like we have that Medvision Sonosim, where we can teach the students about the ultrasounds. Then in pseudo VR, the virtual anatomy tables we have, like Anatomas virtual dissection table, where you no longer need a cadaver, you will use the virtual table and you can do all the dissection process over there. Then there are hybrid systems. In these, the combination of high fidelity virtual reality things are included, and they are best for the complex team dynamics training, and simultaneous interdisciplinary training is possible. Suppose you are creating an operating room environment, you can do any surgical process and simultaneously in anesthesia or nursing training and the technician trainings also. Examples are hybrid angio suites, where you can perform the angiography or the PTCA, or hybrid simulation ICU, where all the patients are high fidelity mannequins, nursing personnel are there, you have to take rounds. These will give you a immersive experience. Yes, there are evidence that that these simulation teachings do help in real life, like that an article by H.S. Squire, G. A. Rookie, and Milonsky and Ross. They showed that skin-based anesthesia simulation with debriefing improves the performance in a mannequin-based anesthesia simulator. There are many different examples. I'm not going into the details of that. You can, that I will be sharing the slides show, so you can, take this from my presentation. So, what are the best teaching practices? You have to give them the orientation, introduction to the session, self-assessment, debriefing, and after that evaluation. And continue with their teaching practices, determine what to be assessed. These are things. Then design a simulation that provokes that performance, observe and record the performance, analyze the performance, debriefing feedback and teaching, give opportunities for repetitive practice, integrate simulation into the overall curriculum that we have already done, provide increasing level of difficulty, provide clinical variations in the scenario, and define outcome. So that's all about the simulation today. But before I end, remember one thing very clearly, that simulation is one tool in our educational repertoire. It can't replace the patient-based teaching. Remember that. That is the main take-home message today. And I like to acknowledge because Dr. Ritesh Kumar, the Maverick, Dr. Joseph X. Brunner of Neosim, Switzerland, CA USA, Anna Thomas UK, and AQI GmbH in Mainz, Germany, because for providing me with the valuable support and technical tools to go through this simulation teaching, so I can that give this lecture in front of you. Thank you very much.